Okay, everybody, we are going to move on from where we stopped. You guys had a little bit of a break to do some research that hopefully you learned quite a bit, and you will be good and prepared for um, your help you prepare for that phlebotomy part. I know I kind of jumped ahead a little bit, but it was a little break from actual lecture. So we're going to pick back up where we left off. We only watched one of the two urine dipstick test procedures, so we're going to watch the other one now. And this one's just real short. Talks about culture. And some of the containers are pink, and some are sterile containers are green, and some are even a white top. See how they're very careful not to touch the stick of the Vacutainer, the disposable Vacutainer? And then once you completed this portion, then you would do your urine dipstick to test for bacteria, ketones, WBCs, protein, bacteria, leukocytes, all those kind of things. So just remember that, okay? All right. That is all of that video. And let's get back and keep moving. So another kind is drug screen, and that actually is in the wrong place, and I'm going to apologize for that and see if I can't get it moved. I'm not sure why it's there. Give me a second to go back and see if I can figure out why that ended up in the middle of the page. It should not have, because it should be down on the bottom. Well, as you can tell, I'm having some technical difficulties today, but let me try to move that down here and see if that will work. Because it's the same one, it's just above it. So I'll just kind of leave that there. Okay, sorry about that. Now we're going to talk about urine drug screens. So there are two kinds of urine drug screens that can be done in a facility. They are either a CLIA-waived urine drug screen, which is basically done, UDS stands for urine drug screen. Those are painless. They're not very difficult to they're not difficult to handle. They come in a very specific container. Some of them, they urinate in them, you shake it, and it tells you. Sometimes they sit in the container, and it sits for so long, and it will basically pull urine into the testing screen, and it will tell you what it's positive or negative for. Normally, these kind of urine drug screens are done for your patients who are prescribed opiates or other controlled substance, so that we can be sure that they are taking their opiate, but also that they're not taking other street drugs or drugs that they're not prescribed, like Xanax or Ativan or Valium, along with other illicit drugs or street drugs that they shouldn't be taking. This is not a DOT drug screen. Now, a DOT drug screen is one that's a chain of custody, and we'll look at a chain of custody drug screen at a later date. But and you have to be special. You have to have special training, and you have to be certified to do a DOT urine drug screen. But this regular urine drug screen can be done by any medical assistant at any time that the doctor orders it, just for them to verify the patient's not utilizing drugs that they should not be. So let's watch this video real quick so that you know how they're performed. And I hope these videos are helping pull everything together for you so you can see,
Welcome
not just...
Welcome to the drugtestinbook.com specimen collection and preparation video. Welcome to the drugtestinbook.com specimen collection and preparation video. When to collect urine for the test. You may collect urine samples within detection time after suspected drug use. Collection time is crucial to detecting any drug of abuse. Each drug is cleared by the body and is detected in urine at different times and rates. How to collect urine. Remove the test cup from the foil pouch by tearing at the notch. Use it as soon as possible. Open the cap of the test cup and urinate directly into the cup. The urine sample should be above the minimum urine level scale located on the left side of the cup label. Wipe off any splashes or spills that may be on the outside of the cup. How to collect urine. You may observe the temperature strip affixed on the test cup between 2 to 4 minutes to see if the urine is diluted by water or liquid other than urine. The temperature range 90 to 100 degrees Fahrenheit is acceptable. It is important to remember that the urine sample should be above the minimum urine level required for proper testing. The minimum urine level is located on the left side of the cup label. How to do the test. Test must be in room temperature 50 to 86 degrees Fahrenheit. After collection. After the urine has been collected, recap the cup and place the teacup on the flat surface. Peel the label from right to left and read the results within 5 minutes. Do not read the results after 5 minutes. Reading the results. Preliminary positive. A rose-pink band is visible in each control region, and no color band appears in the appropriate test region. This indicates a preliminary positive result for the corresponding drug of that specific test zone. Negative. A rose-pink band is visible in each control region and the appropriate test region. It indicates that the concentration of the corresponding drug of that specific test zone is below 0 or the detection limit of the test. Invalid. If a color band is not visible in each of the control region, or a color band is only visible in each of the test region, the test is invalid. Another test should be run to reevaluate the specimen. If the test still fails, please contact the distributor or the store where you bought the product with the lot number and expiration date. Note: there is no meaning attributed to line color intensity or width. A preliminary positive test result does not always mean a person took illegal drugs, and a negative test result doesn't always mean a person did not take illegal drugs. There are a number of factors that influence the reliability of drug tests. The result you obtained is called preliminary for a reason. The sample must be tested by a laboratory in order to determine if a drug of abuse is actually present. Send any sample which does not give a negative result to a laboratory for further testing. Please contact us at 866-465-2855 and we will assist you with a laboratory setup. What is a false positive test? The definition of a false positive test would be an instance where a substance is identified incorrectly by the multi-drug urine test cup. The most common causes of a false positive test are cross-reactants. Certain foods and medications, diet plan drugs, and nutritional supplements may cause a false positive test result with the product. The definition of a false negative test is that the initial drug is present but isn't detected by the multi-drug urine test cup. If the sample is diluted or the sample is adulterated, that may cause a false negative result. Test limitations. This test has been developed for testing urine samples only. No other fluids have been evaluated. Do not use this device to test anything but urine. This test is a qualitative screening assay. It is not designed to determine the quantitative concentration of drugs or the level of intoxication. Adulterants, such as bleach and/or lume in urine specimens, may produce erroneous results regardless of the analytical method used. If these adulterants are suspected, the test should be repeated with another urine specimen. There is a possibility that technical or procedural errors may cause erroneous results. A negative result may not necessarily indicate drug-free urine. Negative results can be obtained when the drug is present but below the cutoff level of the test. Test does not distinguish between drugs of abuse and certain medications. The adulteration assays are for screening purposes only. All abnormal results should be confirmed by an alternative methodology. Thank you for watching.
Okay, guys, so basically what they're saying is that's a preliminary that tells you whether or not it's there. Most doctors will all order initially that qualitative, which means is it there, is it not there, and then they can send it off for a quantitative, which will tell them the amount of that particular drug that's in the system. Okay, so next we're going to talk about finger stick blood sugars. You guys will do these a lot. It is just a capillary. You'll use a lancet and collect a capillary specimen. It will go on to a diabetic monitor or a glucose monitor, and it will give you an immediate results. Those are called random finger sticks. A fasting finger stick, which is what sometimes are ordered. Fasting means they haven't had anything to eat or drink in the last at least 6 hours. So that would be a fasting blood sugar. But when you do a finger stick blood sugar, it's random and it gives you the results on blood sugar levels at the moment. There are things that can make blood sugar levels off or make these results wrong if the person didn't wash their hands, if there's still alcohol on the finger, if the finger is still wet. If the finger is wet, it'll dilute it. If there's alcohol, it'll make it left on the finger that's not dry. It will make it much lower than it should be. So when you clean someone's finger to do a finger stick blood sugar, you're going to be sure that that it has dried. It's had appropriate time to dry before you stick their finger to collect that blood sugar. Also know that with almost every CLIA waived monitor, the control must be done before every check. Okay? All right, let's watch a video on how to do a finger stick blood sugar. This guy is from Australia, I think, but the process is exactly the same.
Back again with this week's video. This week, we're going to learn how to use a lancing device and a blood glucose meter. Back again with this week's video. This week, we're going to learn how to use a lancing device and a blood glucose meter. But most importantly, I'm going to teach you some really useful tips that everybody should know. So, this is my lancing device that used to obtain a sample of blood, usually from the finger, for our blood glucose meter. Here's the first tip. Wash your hands with warm water and normal soap before you begin, and make sure you dry them. Now, warming your hands gives the puncture site better blood flow, so it's easier to collect a sample. Rubbing your hands also helps with this. To load the lancing device, it's pretty simple. You first twist this cap off, then you get yourself a lancet that hasn't been used, pop it in so that the grooves are in line. Next, twist this cap off, and now the needle is visible, so please be careful. Next, get this cap, pop it back on, twist it on, it should click, and that's it. Tip 2, use a new lancet every time you use your lancing device. I know it's time consuming, but remember this. Every time you use your lancet, the needle becomes dull, so 1, it's going to hurt more, and 2, you're at risk of a skin infection. Next is the depth indicator, which is the thing that I'm twisting here. And it adjusts just how deep the lancet tip will go into your finger. Now, this isn't something that I can teach you on a video. You'll have to do it a couple of times to get the correct setting for yourself. Tip 3. This is what we call the pad of the finger. It has more nerve endings compared to the side. So for less pain, when using this, go for the sides and switch fingers regularly to prevent thickening of the skin. If you're still in pain when you're using this, then speak to your healthcare professional about getting thinner lancets. And lastly, pull the sliding barrel back so it locks into place the spring-loaded lancet that we fitted earlier. Place it on your skin firmly and click the button so it releases the lancet to puncture your skin for the blood sample. So often I see patients' blood glucose meters and their control solution has never even been opened. If you're not testing your machine or your test strips, how can you be sure you're getting the right readings? Do you want me to do your next scene? Sure. So tip 4 was meant to be done by Lewis in the last scene, but he couldn't remember his part, so I'll just have to do it. So perform a control solution test each time you open a new vial of test strips or you feel like your meter isn't working properly. Let's say it's giving an
Now this example is for maybe the lay person, so it actually helps you help someone to teach someone to use a lancet and a glucometer, but the same process is done, and many times we use the same type of meter in the clinic as we do at home.
Expected results, or you may have dropped it or damaged it. Now I've left more information in the description below about this. So, continuing on from our lancing device part, to test our blood glucose, we need to get a few things ready. So we need a glucose monitor, its specific test strips that are in date, a primed and ready to use lancing device, which we did earlier, a cotton wool pad, a yellow sharps pin, and a monitoring diary so we can put our results in at the end. Next, remove a test strip from the vial and insert it into your blood glucose meter. It should switch on at this point and warm up, and it will tell you when it's ready for your blood sample. Now, a word of warning for the next scene, there will be a little bit of blood, so if you don't like the sight of blood, skip forward maybe about 30 seconds. I'll put the information in the description too. Now let's do it. Place the lancet device firmly on the side of your finger, press the release button and remove the device from the puncture site. Warming up your hands makes it easier to get blood without applying pressure. If necessary, apply very light pressure to the surrounding area until a blood drop appears. Now wipe away the first drop of blood with a clean cotton swab. With the second drop of blood, be careful not to smear it, make sure your meter is ready and gently touch the blood drop with the test strip to collect a blood sample. The test strip will draw the blood towards itself. After a few seconds, the meter will display your blood glucose level. Write this down with any other information in the monitoring diary or update your electronic records.
Okay, so that's the most important part, and then you're going to throw away your strip and you're going to dispose of your lancet appropriately in the sharps container. Just be sure that, I mean, this is something that you will do so many times throughout your career as a medical assistant that you could do it with your eyes closed. The most important things to remember are changing out that lancet, doing your control, making sure the patient washes their hands, go ahead and cleaning their finger with alcohol swab, letting it dry, wiping off that first drop of blood, using that second drop of blood, and then disposing of everything and wiping down your meter. You always want to wipe down your meter after it's been used because it's in a patient's room and you potentially could have accidentally gotten the other person's blood on it, and you're going to take it in another room with another patient eventually. All right. Now we're going to talk about hemoglobin A1C. Hemoglobin A1C is a test that is basically a finger stick test as well. And it is done to check for those diabetics that maybe they're or someone who we come in and we test them 6 months ago and their blood sugar's been normal, and we we do a blood test on them, their normal blood, CBC, CMP, TSH, all that kind of stuff on them for the year. And when it comes back, their blood sugar's been high. So we may have them come back in and do just a random hemoglobin A1C on them in the office. It is a CLIA-waived procedure with specific devices, specific methods. A diabetic, someone who is a true diabetic, should have this done at least twice a year. And it tests their blood glucose, an average of their blood glucose for the last 3 months. So it's really important. It gives the doctor a good average about how well they've been maintaining their blood sugar, because maybe they did random blood sugar and they had donuts before they came. So their sugar may be spiked, but they may have had a stable blood sugar over the last, 3 months. So we want to be sure that we remind our doctors, because Medicare, it's a Medicare thing that Medicare actually prefers it to be done every 6 months for diabetics and once a year for everyone else. So let's watch how to do one of these. And this is the kind of machine that's used most commonly in facilities for a CLIA-waived A1C. I'm sorry, our internet does this every time where it repeats it.
To begin performing A1C patient tests, it is best to have available all items necessary for the test before acquiring the patient sample. Please refer to the quick reference guide for an illustrated procedure for performing A1C testing. You will need the following: DCA hemoglobin A1C reagent kit with reagent cartridge and capillary holder. You should be using a reagent lot number which you have previously calibrated. The DCA Vantage Analyzer will notify you if you try to run a test on a previously uncalibrated reagent, or you can search the DCA Vantage memory to view the lot numbers which are stored in the calibration memory. Please refer to the Recalling Calibration Data section of this video or the operator's guide for more details. Patient sample. Lint-free tissue. And you will want to unwrap a reagent cartridge and capillary holder prior to collecting the patient sample. Now you will learn how to remove the A1C reagent cartridge from the foil package by following these steps. Remove one foil package from the reagent kit. Open the foil package. Remove the reagent cartridge from the package. Caution: when handling the reagent cartridge, do not touch or otherwise contaminate the optical window, or erroneous test results may occur. Next, you will need to remove and open the capillary holder. Open the plastic wrap of the capillary holder by tearing the wrap at the serrated edge with the arrow. Inspect the capillary holder for the presence of the following parts: absorbent pad, glass capillary, latching mechanism. If the capillary holder is missing any of the above parts, discard the capillary holder. Note: you can save unused capillary holders and use them with a lot of DCA hemoglobin A1C reagent cartridges. Now you will fill the capillary with patient sample. Once the capillary is filled with the sample, analysis must begin within 5 minutes. The blood sample can be from a finger stick or a venipuncture as per the following directions. 1 microliter of blood is required to fill the capillary. If you decide to use capillary blood from a finger stick, use the following directions. Hold the capillary holder at an angle. Touch only the tip of the capillary to a small drop of blood on the finger until the capillary fills. Using a lint-free tissue, carefully wipe the outside of the glass capillary. Inspect the capillary for any bubbles and discard if present. If you decide to use whole blood obtained by venipuncture, use the following directions. Mix the sample well, by inversion or use of a tube mixer, to prevent separation of red blood cells and plasma. Remove stopper from the blood collection tube in such a way that a small sample of blood remains on the stopper. Hold the capillary holder at an angle. Touch only the tip of the capillary to the blood sample on the stopper. As an option, you can use a transfer pipette and bulb to draw up a small amount of sample, and then use the capillary holder to acquire the sample directly from the end of the pipette. Using a lint-free tissue, carefully wipe the outside of the glass capillary. Note: do not allow the tissue to touch the open end of the glass capillary. Contact with the open end of the capillary could result in loss of sample by wicking into the tissue. If sample loss is obvious, discard the capillary holder and repeat the procedure using a new capillary holder. Inspect the glass capillary for presence of bubbles. If bubbles are obvious, discard the capillary holder and repeat the procedure using a new capillary holder. You will need to insert the capillary holder into the reagent cartridge within 5 minutes of collection by doing the following. Carefully insert the capillary holder into the reagent cartridge until the holder gently snaps into place. The next step is to scan the reagent cartridge so the instrument knows which test and lot number reagent you are using and to check for a valid calibration. The scanning process is as follows. Locate the dot on the system next to the barcode track. Locate the barcode on the reagent cartridge. Hold the reagent cartridge so that the barcode faces to the right. Insert the reagent cartridge above dot into the barcode track. Quickly and smoothly slide the reagent cartridge down. A beep sounds to signal a successful scan. Note, if no beep sounds, repeat procedure. The final step is to insert the reagent cartridge into the DCA Vantage Analyzer as follows. The display will show the following steps. Open the cartridge compartment door. Hold the reagent cartridge so that the barcode faces to the right. Insert the reagent cartridge into the cartridge compartment until a gentle snap is heard or felt. Note, the cartridge is designed to fit only one way into the system. Do not force the cartridge into the system. Using a smooth, slow, continuous motion, pull the flexible pull tab completely out of the reagent cartridge. Close the door and dispose of the flexible pull tab. The A1C results will be completed in 6 minutes. You can cancel a test anytime. To cancel a test, select Cancel. Note, if a test in progress is canceled, you must discard the reagent cartridge. The result screen displays when the system finishes analyzing the sample. The screen displays result values and demographics for each test. You can edit the sample demographics and comments at the sample data screen prior to printing by selecting the Edit button. You can also print the result by pressing the Print key. The following provides some additional details on the A1C result. The A1C test result displays the hemoglobin A1C percent. The reporting range for patient samples is 2.5% to 14.0% A1C, and for control samples is 2.5% to 16.0% A1C. The test is linear throughout the range.
All right, guys, so you saw how that was. Yeah, that one's a little more complicated than most of the CLIA-waived testings that you will do, but this one is available to be done in-house. And it takes, like it said, it takes about 7 or 8 minutes, 7 to 10 minutes to complete this test from beginning to end. So just know that you may have to put it in the machine and then walk away, take some vital signs, come back and pick those up. All right. So we're going to talk about some other kinds of tests that you do that are point of care testing that you will do as a medical assistant. Vision testing is definitely one of the things that you will do, especially with kids and on yearly exams. You'll do a visual acuity test with a Snelling chart, and basically you'll have the patient stand 20 feet away from the chart. It's the chart you guys are normally used to seeing when you went to the PD clinic that has the big E, and then the letters get smaller as you go down. You can also do some colorblind testing or vision color testing with that one as well, preliminary, because you can, there's a red and a green line on there, so you can ask them if they can tell the difference between red and green. And there's more than one kind of color testing that can be done. Know that males are more oftenly colorblind than females. Most colorblindness, that's why the red and green line are on the Snelling chart, because most colorblindness are red and green. And then there's also a book test that can be done. But we're going to watch someone perform the colorblind test. Also, sometimes doctors will stick like a yellow sticky in the top corner over by the E or something like that, so that you can ask the colors red, yellow, and green. Anyway, so let's watch an eye exam being completed, an explanation, so you can actually see that. Give it just a second to load. I'm sorry, guys. Everything always runs slow here in the mornings. And then we will actually stop after this one, and
Hi.
you guys we'll stop after this. This optometrist explains, and then you guys will have some reading to start over the phlebotomy portion.
Hi, welcome to How to Check Visual Acuity. My name's David Keegan. I'm an academic family doctor here at the University of Calgary. So there's a whole bunch of times when you're going to want to check people's visual acuity as part of preventive health care, but also sometimes when they have like an eye injury or there's some sort of eye condition that they have, like a sore eye or a red eye of some type or other. Being able to check the visual acuity in a careful, controlled way really helps you understand what kind of disease somebody might have or just in general how their vision is. And the key thing is doing it in the right way so that it's reliable, so that the visual acuity you measure can be relied upon by yourself later or by other people later who are caring for the same patient, so that you can track improvements or worsening, or so that we can all sort of understand what what the visual acuity the patient had at the beginning. So here's how you do it. First of all, you'll be familiar with this chart, a Snellen chart. It starts with the big E on front and goes down to the letters. So you'll notice that there's numbers on the side, and they all start with the number 20. And so if your metric is 6.1 meters. So the patient whose vision you're checking has to be 20 feet away from the chart, and not about 20 feet. You should actually measure it out and have exactly that marked on the ground where that line is for the person to line up with their toes. So when they're 20 feet away, you get them to cover up one eye. Now, if you're really stuck, you can use their hand. But the problem is people can peek through their fingers, just like I'm doing right now. And so instead, you should better have like a paddle or a piece of paper, some sort of card, something like that is handy. I find actually, frankly, a prescription pad might be handy if you still have prescription pads or something like that. So you get them to physically cover up their eye, one of their eyes, and then with their other eye that's open, you get them to read from the top slowly. Now, what you've got to do is you've got to be watching the chart and watching the patient at the same time and kind of glancing back and forth. After a while, it's kind of handy if you have this memorized. It's very handy because you want to make sure that the patient is still doing things properly, just to make sure they didn't drop their hand and are using two eyes instead of one, that kind of thing. So you get them to read from the top. And the number that you will score, eventually, you're going to give a short number. It indicates the best that they could read. And so if they can only read E, for instance, the top E, the number next to that says 2200. So 20 over 200. What this means is that this person can see at 20 feet what a person with normal vision can see at 200 feet. So that's pretty bad. If that's all they can see, this is pretty bad. Pause. My eraser. Where's my eraser? There it is. Got the eraser. Sorry about that. Now, let's say the person can read down to this line, FP, and they get it accurate. Well, then they're at 20 over 100. If somebody can read down to the next line, TOZ, they're 2070, and so on. You get the picture. So normal, is kind of defined as 20 over 20. DEFPOTEC, DEFPOTEC. So DEFPOTEC, that's a phrase you'll just kind of get used to and remember. It's quite handy because if sometimes you have somebody, you just sort of check. Can you read just above the red line? And if they can read that off, great. You know that you're good. But normally you start from the top and work down. So let's say if somebody can read DEFPOTEC without any errors, then they get 20 over 20. And let's say they cannot read any letters here. So the next line, LEFODPCT, let's say they can't read any letters there at all. Well, then this is their score, 2020, because they got to the 2020 line, DEFPOTEC, but didn't get any of the 2015. So that's in a basic form, which is the line that somebody can read all the letters. That's their score. The smallest letters that they can read, that's their score. But what do you do, though, if, yes, somebody can read this DEFPOTEC, And they can read some, but not all of the next letters. Well, that gets a bit trickier. So let's just go back up to the top of the eye chart, and I'll give you an example. Let's say you got somebody here, and their vision is like this. This is what they can see. They read E, F, P.
Hey
say,
guys, sorry,
not
my
sure what that
computer
is,
has frozen
and
up.
O and Z. Well, this is at the 2070 line, 2070, and because they made one mistake or couldn't get one, it's 2070 minus 1.
Okay, let me try to see if I can get it to play.
If similarly, they could only read this, E, F, P, and then they say, I'm not sure, O, and they say it's P, but in fact it's a Z, or if you're in the United States, a Z. So they've got two errors on the line. That is 2070 minus 2. Now you're only allowed to have two errors. If you're further on down here, and let's say you're on this line, and they can read EFP, TOZ, or Z, LPED, and they go Q, E, L, Q, D, and so they only get two correct on this line. Their score is not, so you might think their score is 2040 minus 3, but no, 3 mistakes is just too many. You get 2 mistakes only. Their score is a line above, 20 over 50. That's their score. And once somebody's got several errors in one line, you basically stop there. You usually don't go to the next line, because if they got a whole bunch of errors on this line, then they haven't got a hope on this line. So to recap, you get them to read usually from the top down. You're looking for which lines can they fully do as farthest down. And then if they hit a line where they've got some errors, as long as the errors are only up to 2, they get that line minus 2 or minus 1. Or if they get more than 2 errors, let's say they have 3 errors, like in this case, they don't score this line at all. Their score is 20 over 50 for this line. Then, so let's say this is somebody's right vision. Then you do the same thing again for the left. So let's say somebody can read all the way down here, but can read all this except for this one issue here. I want you to look at it and think, what would be their score for their left eye? Just to help you, this is the 2050 line. This is the 2040 line. This is the 2030 line. And they can't read anything more below it. So this is all they can read. What would be their score? So the answer is, the furthest lowest line, where at maximum they have 2 errors, is this one. So it's 20 over 30, minus 1. Because they have 1 error, 1 letter they couldn't see properly. Great. And then you usually repeat the vision for both eyes. That's more for driving purposes, to make sure somebody can drive properly. If you're looking for somebody who's got like a red eye in one eye, you want to compare the two and just sort of see where they are. You may not have to actually do the dual vision, unless, again, you're checking to make sure they can drive safely. And the regulations will vary by province and state and country. So that's a quick spin on how do you check.
Okay, we're going to stop there with this, but just know that when you document it as a medical assistant, you have to document it that way: 2050, 2030 minus 1, 2030 minus 2, 2040, 2020. You're going to document that in the chart that way specifically, so that when the doctor looks at those results, he can refer them to an optometrist or ophthalmologist. Also, you want to be sure that You do a left eye, a right eye, and both eyes every year. And then, like you said, if they're in for an eye injury, you're going to do one eye or the other. When you ask them to cover their eye, if you don't have an eye cover, there are some specific little black eye covers that you can have in the clinic. But if you don't have one, you just have them cup their hand and cover their eye very quickly, or you stand back by them and you cover their eye loosely with a sheet of paper where they can't see through it, something like that, so that you're getting a good visual screening of both eyes. When you go get a driver's license, they only screen both eyes usually. But just know that is part of your yearly checkup for a patient, is to do eye screening. If you work in a PD clinic, you're going to have shapes as opposed to letters for younger children under the age of 6 or 7, depending on what your clinic does. But usually you're going to use the shape version, or one that has a bunch of E's in different directions for someone who can't read. It'll have an E, and they'll ask them what direction it's pointing. So there are ways that for people who cannot read or write, for people who don't know letters yet, for children, that there are other forms of this Snelling chart that you can use to get the visual acuity done. We'll talk about hearing acuity and colorblind, checking for color blindness in ways other than just with the colors, the color lines. All right, I hope you all have a great day. You're going to have some reading to do also. Be sure that's done, because you will have a quiz over that the next class day, okay? Everybody have a great day. Thank you so much.